So this is the March 2024 MEC Minute, and topic this month is going to be acute non-traumatic abdominal pain. I thought I'd switch it up a little bit. The past couple of months I've been doing a lot of things that are protocol heavy and focusing on things like behavioral emergencies. I thought for this month we get back to meat and potatoes, EMS. So let's talk some about abdominal pain. So what we're going to do today, we're going to review and discuss common causes of abdominal pain. I'm going to talk about a good number of them, but I'm going to get into detail for only a few of them. I'm going to provide some tips in terms of evaluating, examining the abdomen, and how your examination might guide you in terms of coming up with tentative diagnosis or impression of the patient's problem. I also want to get into a little bit of detail regarding some life-threatening causes of abdominal pain. These are the things that you really don't want to miss or don't want to not think about if the patient has the right symptoms and findings on exam. And a real quick brief review of VMS management of abdominal pain. So common causes of abdominal pain, things like gastroenteritis, nausea, vomiting, diarrhea, pancreatitis, acute inflammation of the pancreas gland, bowel obstruction where there's a kink to the gut, either the large bowel or small bowel, or both, where transit of food and other materials through the gut is impaired. Acute cholecystitis or acute gallbladder pain is a common event, as is acute appendicitis. Kidney stones can be a source of back pain or abdominal pain or both. Urinary tract infections can cause abdominal symptoms or can cause flank pain, depending on whether it's an uncomplicated cystitis or bladder infection, or if it's progressed to where the kidneys are infected and the patient now has pyelonephritis. For women, always think about pregnancy and its complications. We joke in the emergency department, every woman of gestational age or of who's capable of having children is pregnant until proven otherwise. So you always have to think about pregnancy and its complications. Other gynecologic things we need to think about are ovarian cysts and ovarian torsions, as well as pelvic inflammatory disease. Pelvic inflammatory disease is infection of the tubes and ovaries, typically due to a sexually transmitted diseases, but occasionally not. Always think about hernias. Umbilical or belly button hernia or inguinal hernia in the groin. You can also have ventral hernias, which are hernias through the abdominal wall and the front part of the abdomen, usually associated with previous surgery and a surgical scar. Think about acute diverticulitis, patient with left lower quadrant abdominal pain. Acute diverticulitis is a common reason for presentation in the emergency department. Otherwise, there's things like inflammatory bowel disease, like Crohn's disease or ulcerative colitis. Most of the time, patients already have a diagnosis of inflammatory bowel disease, but not all the time. There's also something we're seeing more and more that's causing abdominal pain and vomiting. It's called cyclic vomiting or cannabinoid hyperemesis syndrome. Patients who consume marijuana or cannabinoids heavily can develop this syndrome, and the treatment is to stop utilizing cannabinoids. That can be a very difficult conversation to have with patients. But we have some patients out in our communities that have recurrent nausea and vomiting because of their use of marijuana products. Typically, they're of the younger age. And then the last thing to think about is acute urinary retention. This could be the older patient is complaining of suprapubic abdominal pain, so they have a lot of pain above the central pelvic area. And if you feel the belly, you can feel this tender, tight mass. Well, that's a distended bladder, and the patient needs a Foley catheter. It's amazing how you put a catheter in, all of a sudden these patients feel much improved. So patient assessment. So what things do you need to do when you have a patient with a complaint of pain? And some of these things apply for everybody. Some are questions you'll ask based on earlier questions in your conversation with the patient. So patient's got abdominal pain. When did it start? Where is it? Did it start gradually or abruptly? Typically, we worry more about patients where their first symptom is pain. So if the patient's got a little GI upset, maybe some nausea, and now they got belly pain, that's different than they were well 1 minute, the next minute they were having severe pain. Pain is the first and early symptom, tends to be more concerning. Is there pain associated with nausea and vomiting? What does the pain feel like? Have they had any previous abdominal surgery? So, if the patient's had previous abdominal surgery, then you think about complications of surgery such as bowel obstruction or adhesions or hernia. Have they had any previous abdominal problems? So, several of the conditions we talk about, if the patient's had it before, they're more likely to have it again. So if they've had a history of diverticulitis, have a history of bowel obstruction, they're more likely to have another episode in the future. So, if previous bowel obstruction and now you think they're having symptoms of bowel obstruction, it's more likely a bowel obstruction. Have they had or do they consume alcohol? So that's a big thing when we think about peptic ulcer disease, big thing when we think about pancreatitis. What have they done for the pain? Have they tried Tylenol, antacids, milk of magnesia, whatever? If they're female, when was their last menstrual cycle? For anybody, do they have any urinary symptoms, any blood in your urine? Does it hurt to pee, and so on? And then for the physical exam, is the patient sick or not sick? Take a look at the abdomen. So this is similar to abdominal trauma. If the patient's got an abdominal complaint, take a look under the shirt, under the pants. You have to inspect. Do you see any obvious hernias? Do you see surgical scars? Assess the abdomen. Is it distended? Is it hard or is it drum-like? If you tap on it with your fingers, does it make a sound like a drum? We call that tympany. A belly that's soft and minimally tender is a whole lot different than a belly that's hard, tender, and drum-like when you tap on it. Take a listen to the bowel sounds. What do you hear? Do you hear normal gurgling of the belly? Do you seem like they're hyperactive, or is the belly quiet? So, what do you hear? And then lastly, palpate. Are they tender? If so, where? Do they have guarding or rebound? So guarding is it hurts to push down. Rebound is it hurts if you abruptly let go. So, take a look at those things and see what you come up with. So if you look at the belly, this is just a picture, and you can kind of break it up in this section. We've got it in 9 parts. Typically, we do left upper and lower, right upper and lower. But if you look at it, the right upper abdomen is where you can have symptoms related to gallstones or pancreatitis or peptic ulcer disease. Kind of the central abdomen upper is pancreatitis, gallstones, benign GI upset like a stomach ache. And in the left upper quadrant, it can be more like pancreatitis or something going on in the small bowel. As you get around toward the middle of the belly, you think more about appendicitis. Let me get through the dots here. You think more about appendicitis. Typically, appendicitis starts more in the belly button area, but with time it moves down to the right lower quadrant. Patients who have kidney stones can have either left or right flank tenderness. The left side of the abdomen tends to be more where we'll see problems related to constipation, inflammatory bowel disease, or diverticulitis. In the lower abdomen, we think about appendicitis, constipation. We think about gynecologic causes of pain, such as ovarian torsion, ectopic pregnancy, and so on. If the patient has lower abdominal pain, also think about, could they have inguinal hernias, particularly if you think the patient has a bowel obstruction. If you look at the elderly population, the 2 most common causes of bowel obstruction are either surgical scars and adhesions or ulcers, or inguinal hernias. So take a look. Do they have any evidence of bulging, any evidence of a hernia? So this is kind of a quick roadmap of what symptoms may be coming from different areas of the abdomen. So let's talk about some common conditions. Acute appendicitis. I had one last night, not me, but a patient. And a patient really followed this. He had a gradual onset of symptoms about 18 to 24 hours before he came in, kind of some vague abdominal discomfort, some nausea, loss of appetite. He vomited a couple times. And the pain really started in the epigastric area and around the belly button. And then with time, it progressed, localized in the right lower abdomen. He developed tenderness. He had pain with walking and bouncing. He had a lot of discomfort when his spouse drove him to the hospital when she hit a pothole. On exam, he had a lot of guarding and rebound in the right lower abdomen, so I pushed down and it really hurt. And if I abruptly let go after pushing down, he came off the bed. Acute appendicitis typically evaluated by laboratory work and CAT scan. And we have an agreement with our radiologist, no matter what the reason, if we order a CAT scan of the abdomen, they always make a comment about the appendix. Do they see it? Yes or no? If they can see it, does it look inflamed or is it normal? So acute appendicitis is out there. There's something called a retrocecal appendicitis. It's where the appendix is hidden behind the cecum or the first part of the colon. These patients can have very atypical symptoms. In the years past, before we used CT imaging as often as we do now, in years past, it could be very difficult to make a diagnosis of retrocecal appendicitis. These days, it's much easier to see with abdominal CT. Treatment for appendicitis is typically surgery, although there's literature out there to suggest you could be treated with antibiotics and not require an appendectomy. For me, the thing to consider, though, is a significant number of those patients who are treated with antibiotics end up coming back with a recurrent episode and then need surgery. So I think, you need to think about, are you going to have your surgery and have your appendix out, or you're going to be on antibiotics? I think at this point I would vote for the appendectomy, since it's a relatively straightforward procedure and I'm already inconvenienced. Let's just get this over with. But something to think about if you have appendicitis in the future. Another thing we see commonly is acute bowel obstruction. So there's a kink in the gut and the gastric contents are not, and the bowel contents are not being moved through as they should be. So the peristalsis of the gut is impaired, and the patient can get into trouble. Risk factors, probably the biggest risk factor we'll see is previous abdominal surgery or a history of previous bowel obstruction. After surgery, you can develop adhesions or tight bands within the abdomen of scar tissue, and sometimes the gut can get caught up in that and cause a bowel obstruction. As I mentioned earlier, inguinal or umbilical hernias can become incarcerated. That's where gut becomes trapped in the hernia, and they act as a bowel obstruction as well. So these patients typically have acute abdominal pain. It can be localized or generalized. They typically have nausea and vomiting, and their belly, if you look at it, tends to be distended. It tends to be swollen. When you examine the patient, you see swelling and distension. If you listen, you'll hear diminished bowel sounds. Sometimes you'll hear what we call peristaltic rushes, where the belly seems quiet, and then you hear a lot of tinkling, kind of like a rush of noise, and it gets quiet again. If you percuss the abdomen, you may get some tympany, and sometimes if the bowel obstruction is severe enough, you can actually see distended loops of bowel through the skin, particularly if the patient is skinny and does not have any or much fat of the abdominal wall. You can actually see the distended loops of bowel making an impression on the skin. So how do we treat this in the emergency department? And for you, we'll get IV access. If you think the patient's got a bowel obstruction, don't give them anything orally, and then feel free to treat them per protocol with Zofran and fentanyl. Just what might a bowel obstruction look like? So if you look at the x-ray on the left, this is just an x-ray of the belly with the patient lying flat. You can see these loops of bowel. You can see those white markings going across the gut, across the bowel. This almost looks like a coiled snake. And I got one of the red arrows there that's showing, some of the haustral markings, or which is the markings of the bowel. So that's what it looks like on a plain film. On the right-hand side is a CAT scan. This is what we typically do these days. We can get a CAT scan quickly. If we're thinking about just a bowel obstruction, we do not need the patient intravenous x-ray dye, so we can just get a non-contrast CT. If you look at the top of the CAT scan, the red arrow points out air fluid level. So the grayish material is fluid, and above that is air. This is a bowel obstruction. If you look at the orange arrows, they show you other distended gut, and it's got a lot of fluid and contents in it. So this is what a bowel obstruction looks like. We're going to treat this in the emergency department with a nasogastric tube, get our surgical colleagues involved, give the patient adequate medications for pain. Most of the time these days, we just keep the nasogastric tube in, see how they decompress over a day or two. If they do not improve, then surgery takes them to the OR. Most cases of bowel obstruction are not operated at the time of admission. How about acute pancreatitis? So this is something we'll see. Acute pancreatitis can be caused by alcohol. Probably for the emergency department, the most common cause of pancreatitis is alcohol abuse or addiction. Certain medications can cause acute pancreatitis. Sometimes you can have gallstones, and the gallstones drift out of the gallbladder down into the bile duct. The bile duct runs through the pancreas, and the stone gets stuck in the pancreas, which then puts back pressure on the pancreas, causing pancreatitis. Um, Sometimes patients with elevated triglycerides. So if your triglycerides are, over 500, over 1,000, that puts you at increased risk for pancreatitis as well. And the treatment for that would be management of your hyperlipidemia. And then some patients can develop chronic pancreatitis because of recurrent episodes, particularly if they continue to use alcohol after that first episode of pancreatitis. These patients typically complain of epigastric pain. They may have pain that radiates into their back. If you look at the anatomy, the pancreas is at the back of the abdomen up against the spine, so back pain is a common symptom. They can also have nausea and vomiting. These patients tend to be uncomfortable. They tend to have epigastric tenderness. If their volume contracted, they could be tachycardic and hypotensive. So what do we do for them? In the field, we're going to keep them NPO. We're going to ask them about their past history and their history of alcohol use. IV access is appropriate, and if they're hypotensive or tachycardic, feel free to give them a fluid bolus, and then we treat them symptomatically with some Zofran and fentanyl. These patients can be miserable. Pancreatitis can become life-threatening if it progresses to the point where they actually have pancreatic necrosis or the pancreas gland just breaks down. Those patients can have life-threatening events, and some of them will die. How about acute cholecystitis? So acute cholecystitis or gallbladder disease, common cause of epigastric and right upper quadrant abdominal pain. Risk factors included being female. Females are more likely to have acute cholecystitis or gallbladder disease than men, although men still can get it. Pregnancy does represent a risk factor, and particularly if you have multiple pregnancies. Patients who are obese are higher risk for cholecystitis, and then patients who have a family history of gallbladder disease. Most of the patients I evaluate and find having gallbladder disease or biliary colic have a family member, mother, sister, daughter who has a history of gallbladder disease. These patients typically have right upper quadrant abdominal pain. The pain may radiate to the tip or the lower part of the right scapula. These patients tend to have nausea and vomiting. They can be very uncomfortable. They tend to be complaining of being gassy and belching a lot. So if you ask them as part of their symptoms, they may admit that they have been having a lot of gas, a lot of belching recently. If you look at the patients, they're uncomfortable. They can be having nausea and vomiting. They have right upper quadrant tenderness. They also tend to have something called a Murphy sign, where there's tenderness under the right ribs, and that tenderness increases if you have them take a big breath or if you push your fingers under the right costal margin. So what you're doing is you're putting pressure right on the gallbladder. If it's inflamed, it causes more pain. Some of these patients can have jaundice and fever. That is a bad finding. That suggests that they have a gallstone down in the bile duct, and they may have an infection associated with it. These patients can be extremely sick and may need immediate intervention by either gastroenterology or the interventional radiologist to drain the gallbladder to buy the surgeon time. So the patient can cool off and then have their gallbladder removed a few days later. These patients for us in the field, very similar treatment. It's going to be patient assessment. Think of the bad things, IV fluids as needed for tachycardia or hypotension, and treat the symptoms with Zofran and fentanyl. If the patient's uncomfortable, try to get them comfortable. Well, we've got summer coming up, which means we're approaching kidney stone season. So kidney stones generally are not a problem when they're in the kidney. So these stones are formed in the kidney. They tend to be formed with calcium, although sometimes they can be formed by uric acid deposits. Uric acid is a byproduct of protein metabolism, and it's what also causes gout. But probably 70% or so of patients with kidney stones have a calcium stone. They may have risk factors such as previous history. It's another thing that seems to run in the family. Inadequate fluid intake, such as, summertime, you're outside working, you just aren't taking enough liquids. Bariatric surgery can put patients at increased risk for kidney stones because of calcium metabolism and so on. Patients with a history of gout also could have increased risk for kidney stones because uric acid can form stones in the kidneys. High protein diets or calcium supplements can also contribute to kidney stones, as can some medications. So some medications keep you from secreting calcium in the urine, so it builds up and forms stones in the kidneys. These patients typically have acute flank pain. That pain can be intermittent. The pain can radiate into the groin or the testicle. The patient may or may not have gross hematuria. Most people with kidney stones have at least microscopic hematuria, meaning we can't see it in the urine if you look at it regularly, but if you spin it down in the centrifuge and look under the microscope, there's blood there. These patients tend to be miserable. They can't find a position of comfort. They can be diaphoretic, have nausea and vomiting. If they have an associated infection, then they can have fever and hypotension. Any patients with a kidney stone and associated infection tends to be admitted. Some patients have such severe blockage that we actually have to have the interventional radiologist put a nephrostomy tube in, which is a tube that goes in through the back and into the kidney to drain urine until the urologist has a chance to remove the stone. These patients are treated with fluids, Zofran and fentanyl. In the hospital, we'll do a CT and we'll see if there's a stone and if there's any evidence of back pressure on the kidney. We'll medicate them for pain. We'll check for any associated infection. So if you look at the red arrow on the bottom right, you see that white star lighting up. That's a pretty good size kidney stone. I'd say it's probably, just looking at it, I don't have the calipers that we can get on the CT machine, but it probably looks like it's about 5 by 8 millimeters, which is big. And if you look at the orange arrow at the top, that's a dilated renal pelvis or collecting system. So to the outer edge of that area with the arrow is the normal tissue of the kidney, and then the kidneys drain into the renal pelvis, which is the collecting system of the urine, and that on this patient with the orange arrow is dilated, swollen. That's because there's back pressure from that kidney stone, and that back pressure is because the urine can't drain around the kidney stone. So the treatment for this is going to be pain medication. Patient may either go for a stent put in the ureter, which is connecting the kidney to the bladder, or they may end up with that nephrostomy tube I mentioned, where the interventional radiologist puts a drainage tube in through the back. How about hernias? So, most common types that we're going to see are going to be umbilical or belly button, ventral hernias, which is anywhere in the abdominal wall, or inguinal hernias, which is in the groin. When we identify a hernia, we want to know if it's incarcerated or non-incarcerated. A non-incarcerated hernia means it's a weak spot in the abdominal wall, and there may be some bowel in it, but the bowel is not trapped. The bowel has normal perfusion. Whereas an incarcerated hernia is there's bowel that's trapped in the hernia. The bowel is not being perfused, and it's at risk of developing significant ischemia and death of the bowel. If you look at the picture, the arrow on the left is pointing out a belly button hernia. And if you look at the other two blue arrows, you see some redness of the skin. That suggests that the patient has an incarcerated umbilical hernia. So there's gut trapped in the hernia. It's not perfusing well. There's associated inflammation. What kind of symptoms are these patients going to have? They're going to have swelling. They're going to have pain and tenderness. They may have symptoms of a small bowel obstruction if it's incarcerated. And again, they may have skin redness if it's incarcerated. What are you going to do? We're going to keep the patient's NPO. We're going to start them IV fluids. I know it sounds like a broken record, but Zofran and fentanyl. In the emergency department, we may try to push that gut back in. If we do that, sometimes that relieves the obstruction and the patient does okay. This patient's probably going to get a CT to evaluate further. And this patient's also going to have a surgical consult while in the emergency department. Gynecologic causes. So I always think about gynecologic causes of pain, particularly for lower abdominal pain in women. So questions we need to ask. When was your last period? Are you on any birth control? Have you had a previous hysterectomy? A lot of women confuse hysterectomy with a tubal ligation. So have you had your uterus removed, or have you had your tubes tied? Two different things. Have you had a history of previous ectopic? So if you have one ectopic pregnancy, you're at greater risk to have another ectopic pregnancy. If you are pregnant, have you had an ultrasound yet? So if the patient's 12 weeks along, have they had an ultrasound yet? Do you have a history of ovarian cysts or endometriosis? If you're having any vaginal bleeding, how many pads or tampons have you used? And if you're pregnant and having vaginal bleeding and pain, did you pass any tissue? If you did pass tissue, where is it? Can we take it with us? So things of gynecologic etiology that could cause pain. Always think about miscarriage. If the patient's got a confirmed pregnancy, could they have an abruption of the placenta? That's where the placenta separates from the uterus. It can cause significant amount of pain. Could the patient have an ovarian cyst? Some patients have polycystic ovarian disease. That can be very uncomfortable. Patients may just develop an isolated ovarian cyst. Cysts tend to get bigger as the patients move their menstrual cycle, and then about the time they start having their period in the first week after, the cysts tend to get smaller because the hormone levels are lower. Sometimes you can develop an ovarian torsion. That's where the ovary twists on its stalk. It's very similar to a testicular torsion. That can be very uncomfortable and may require surgery. Ectopic pregnancies can cause acute pelvic pain, and if they rupture, they can become life-threatening. Pelvic inflammatory disease, pelvic inflammatory infections can also cause pain. Typically, these are STDs, but sometimes you can have an infection of the tubes and ovaries for other reasons. Again, treatment, think about high level of suspicion, particularly risk for ectopic pregnancy. So someone who's late on their menses is having severe abdominal pain, think about ectopic, treat them with fluids, treat their symptoms, get them to the hospital. I want to review a couple life-threatening things that you need to be aware of. And always be in your mind. Abdominal aortic aneurysm or AAA, I think all of us are aware of these. They can be immediate life-threatening and they need to be managed. Patient risk factors include male genders. Males are much more likely to have abdominal aortic aneurysms than females. Tends to be in people who are over age 60. Smoking and uncontrolled hypertension are considered risk factors for AAAs, as is hyperlipidemia. So if you have a 65-year-old male with abdominal pain and back pain, there's a history of hypertension, tobacco use, and hyperlipidemia, it's an aneurysm until proven otherwise. These patients can have abdominal pain. It can be severe. They're typically described as being tearing in character. And sometimes if they have an acute rupture, they can have a syncopal episode because they drop their pressure when this thing ruptures. On exam, the patients may be tachycardic or hypotensive. They may be diaphoretic. If you gently palpate their abdomen, you may feel a pulsatile mass in the mid to upper central abdomen. And if you listen with a stethoscope, you may hear a bruit, which is a swish, swish, swish sound over this area. Treatment is IV access and prompt transportation, no stay and play. If you think the patient's got a AAA, particularly if they're hypotensive and tachycardic, package them up, get access as you go, notify the receiving hospital. Help control their pain, but avoid hypotension. If the patient's hypotensive, I think I'd be very careful with pain medications. Excuse me. So this is a CT of the abdomen with intravenous X-ray dye. You can see the letters there saying AAA. If you look at the red hash mark left to right, that is those are the outer edges of the aorta. This looks huge. It looks like it's probably 8 or 9 centimeters in size. Typically, the aorta is about 3 millimeters. That bright white spot in the upper central aorta is contrast. That's supposed to be there. Those white spots to the bottom left of the aorta between 7 and 8 o'clock, that is extravasated dye. That is not supposed to be there. And then you can see that white arrow at the bottom left, that's extravasated blood into the retroperitoneal space secondary to a rupture. So this is a ruptured aortic aneurysm. This patient needs immediate procedures. Most of our AAAs these days are managed with endovascular stents rather than open surgery. Patients do better. They're more likely to survive. As soon as you open up the abdomen and you start decompressing this rupture, patient can bleed out and quickly. So our vascular surgeons these days usually place a endovascular stent in the aorta to bypass the aneurysm and tamponade the bleeding. Next one is not a great formatting a slide, but let's talk about some perforated viscous or guts. This is where one of the parts of the GI tract. It has a hole in it. Now there's free air in the abdominal cavity. We call that a perforated viscous. And these patients typically have abdominal pain. It could be of abrupt onset when this thing ruptures, because when there's a hole that's generated within the gut, the air under the diaphragm or other areas can be very irritating, as well as any contents that may leak out. So these patients can have abdominal pain, can have nausea, vomiting, abdominal distension. On exam, they tend to be tachycardic. They may have a fever, depending on how much time's elapsed from when they perforated till the time you get to them. Their abdominal sounds bowel sounds may be diminished, and the belly can be distended and can be tympanitic. These patients can look miserably uncomfortable and can be very ill in appearing. If you look at the chest x-ray in the middle, you can see the red arrow calls out free air, and that's the black stuff under the diaphragm. The diaphragm is that white membrane going from left to right above the black spot. That whiter spot underneath the dark spot is the liver. So you have air above the liver between the liver and the diaphragm. That's what a chest x-ray will look like. That's how we used to diagnose a lot of these. We'd have the patient go to x-ray, we'd stand them up and do a chest x-ray, and we'd look for the air. Well, we've got a little more modern. So if you look at the imaging on the right, that's a cross-sectional abdominal CT. You can see where the liver is, and then you've got that black stuff above the liver. That is free air. That's free air above the liver and between the liver and the abdominal wall. This patient has a perforated viscous and is going to need to go to the operating room. Another thing we've talked about before, but the ectopic pregnancy. In previous centuries, it was the second most common cause of maternal death. The most common cause of maternal death was childbirth. Every female these days is of childbearing age is pregnant until proven otherwise. So anybody with abdominal complaints that is female and childbearing age, we need to verify they are not pregnant. Because if they are pregnant, they have an ectopic until proven otherwise, particularly if they have lower abdominal pain. What are risk factors for ectopics? Previous ectopic pregnancies. So if you had one, you're at higher risk for another. History of endometriosis, a history of current IUD use, or previous tubal ligation or tubal surgery are risk factors, as are history of sexually transmitted diseases. Sexually transmitted diseases or sexually transmitted infections can cause scarring of the tubes, which make it easier to develop an ectopic pregnancy. Signs and symptoms, typically the most common is vaginal bleeding. So it's not pain, it's vaginal bleeding. Patients can develop hypotension, tachycardia, or orthostasis if there's rupture of the ectopic or if there's bleeding from the ectopic. So I mentioned that ectopics were the leading cause of maternal death, second leading cause of maternal death in the past. That's because these things can rupture and the patient bleeds out and bleeds out quickly. These patients may have abdominal tenderness, particularly in the suprapubic area, and if they have enough blood in their abdomen, if it goes up under the diaphragm, they can have shoulder pain. The diaphragm embryologically comes from your shoulder area, so if the diaphragm is irritated, you tend to have pain localizing in the shoulder. For us in the field, our treatment really needs to be a high index of suspicion. Think about it. If the patient's having severe pelvic pain, they have a positive pregnancy test, no previous ultrasound, and now they're uncomfortable with tachycardia and hypotension. They're an ectopic until proven otherwise. Prompt transport, get IV access, 2 IVs if you can, keep the patient in PO and transport. One thing that we really don't like to see in the emergency department of patients with dead gut or bowel ischemia. This is where perfusion to the gut is impaired. And for us, the biggest cause is embolic events. So the patient can have an atrial arrhythmia like atrial fibrillation. A clot forms in the atria because they may or may not be anticoagulated. A piece breaks loose. That broken piece can either go to the brain and cause a stroke, or can go to the gut and cause bowel ischemia. Sometimes you can have ischemic gut from twisting the gut, like a bowel obstruction, or patients hypotensive and they just have low flow to the gut and they develop ischemia. Always think about gut ischemia in patients with atrial fibrillation and abdominal pain, or patients who've had previous GI surgery. You ask the patients if they're on Eliquis, Xarelto, or Coumadin or warfarin, or do you have a history of atrial fibrillation while you're on these anticoagulants? So the key diagnostic finding for us before imaging is, does their pain seem out of proportion to the abdominal exam? So these patients can be miserable, but if you evaluate their abdomen, it may not be that tender, may not be that distended. That for us is a concerning symptom, and we worry about ischemia, especially if they have atrial fibrillation. They may also have some bloody stool because the gut, as it starts to become ischemic, can bleed. And they tend to have left-sided pain with their gut ischemia, although if it's right-sided, they tend to have worse outcomes. I don't have a good explanation for that. I presume it's because of the way the gut is supplied from a vascular perspective. So how do we manage these patients? Well, again, fluids, NPO, symptom control, high-level suspicion, quick transport if you think the patient's got ischemic gut. These patients need imaging, and they need to go to the OR. Well, the last things we want to talk about here are mimics. So always think about cardiac ischemia, particularly in inferior MI, particularly in patients who have epigastric pain or epigastric and chest pain. They can have nausea, vomiting, dyspnea, and diaphoresis. So a couple times a year, when a patient comes in with upper abdominal pain, we'll get an EKG, and you look at it, and you've got ST elevation, inferior leads. They're not having abdominal pain because of an abdominal issue. They're having abdominal symptoms because they have an inferior MI. So always have a high level of suspicion for this. If the patient's got epigastric pain and some chest discomfort, consider doing a 12 lead in the field, particularly if they're older and have risk factors for cardiac disease. The last thing I want to talk about really has to do with some things we've had to deal with in the past. Should we avoid administering pain medications to the patient with abdominal pain? In the past, there's been concern by surgeons and others that if the patient's having pain and we mask it with narcotics, then we're going to shortchange them in terms of their workup. Well, studies have shown that pre-hospital narcotics do not interfere with ED workup. We use fentanyl, which has about a 30-minute duration of action. We do a lot of imaging and lab work. So really, if the patient needs something for pain control, treat their pain. You should not withhold pain medication because you're worried that it may interfere with the ED workup. By the time the surgeons ever see the patients, it'll be 3 to 4 hours down the road. Any pain meds you gave the patient would have worn off, and chances are I would have already given the patient something as well. So with all the tests we can now do, including medical imaging, there's no reason not to give the patient narcotics in the field if they have a genuine need. So if they have significant pain, treat the pain. So in review, abdominal pain is a common complaint. Most abdominal pain is uncomfortable but not life-threatening. You have to think about sick versus not sick. If they look sick, move fast. Ask questions appropriate for the patient age, gender, and appearance. Past history. When's their last menstrual period? Have they had this previous problem before? Do they look sick? Please take a look at the abdomen. Take a look under the shirt, look under the pants. Is there evidence of hernia, a distension? Take a listen with your stethoscope. I realize the back of a truck is not the quietest place, but try. In the elderly patient, check cardiac rhythm and consider a 12-lead ECG. Again, abdominal pain with atrial fibrillation, we have to think about ischemia. Upper abdominal pain with chest symptoms, think about an inferior MI. Always think about the bad things: abdominal aortic aneurysm, ischemic gut, inferior MI, ectopic pregnancies, and others, and try to make the patient comfortable. So that's all I have for today. If you have any questions or comments, please post them on Basecamp. Thank you.